Thanks, Dave. And over the next 15 minutes, I'm going to talk about how we should be positioning our IBD therapies. So the goals of medical treatment in patients with Crohn's and colitis are to induce a clinical remission, which I've defined here as the complete absence of symptoms, avoid short and long-term toxicity of therapy. In 2020, remission should be steroid-free, and we should strive to avoid repeated courses of steroids. If we do these things, we often enhance patients' quality of life. If we are aggressive with our treatments, we can hopefully prevent complications of disease. Oftentimes, we're dealt with complications from the get-go that we need to deal with surgically. Our targets are expanding from symptom control to endoscopic, achieving mucosal healing or deep remission. And obviously, we want to try to reduce unnecessary healthcare expenditures such as ER visits and hospitalization to try to contain costs. STRIDE has given us targets beyond symptoms. So I've combined Crohn's and ulcerative colitis here in this single slide. So patient-reported outcomes should be resolution of rectal bleeding, resolution of diarrhea, and resolution of abdominal pain, emphasizing here that resolution of symptoms alone is not a sufficient treatment target. Objective targets focus on absence of mucosal ulcerations for both Crohn's and ulcerative colitis. There's a point of emphasis in these guidelines that histologic remission is not yet a target of treatment. And when endoscopy cannot adequately evaluate a segment of inflammation, the resolution or target should be resolution of inflammation on cross-sectional imaging. So what studies do we have that have focused on a treat-to-target approach on outcomes? So this is the CALM study led by Jean-Frédéric Colombel. Treatments here were Adalimumab, monotherapy initially, and if patients were still symptomatic at predefined endpoints or had elevated CRP or calprotectin, the Adalimumab was escalated to weekly dosing, and if they still hadn't met those outcomes, azathioprine was added. The primary endpoint at 1 year was an endoscopic outcome, a CDEIS score less than 4, and the absence of deep ulcers, which was higher, significantly higher in the treat-to-target group compared to the clinical management group alone. If you look at some of the other outcomes, which include symptoms and biomarkers, a treat-to-target approach was also superior to clinical management alone. What would treat-to-target look like in clinical practice? So this would be a baseline assessment of disease activity with an endoscopy paired with a biomarker that was responsive for the given patient. We're going to talk about how to choose initial therapy, and then you're going to do an assessment of clinical symptoms in 2 to 3 months, an assessment endoscopically or with biomarkers in 6 months. If you have biologic remission or endoscopic remission, you continue to monitor. If not, you have a shared decision-making discussion with the patient on options, usually optimization of existing treatment or a complete switch to another form of therapy, and then the cycle continues. So when should you initiate highly effective therapy for Crohn's and colitis? Highly effective therapy I'm going to define as biologic or small molecule treatment. And the decision should be based on these 4 factors. So one is how severe are the patient's symptoms? Second, what is the inflammatory burden present? Third, what are their risk factors for a severe or disabling disease course? And then in Crohn's disease in particular, is there complicated Crohn's disease present? So I'm going to skip over these for the sake of time, but our ACG guidelines for moderate to severe ulcerative colitis do help us to categorize symptom severity based on symptoms, biomarkers, or endoscopy. So in thinking about complicated Crohn's disease, this is a study from the Cleveland Clinic looking at patients with stricturing Crohn's disease, over 240 patients with stricturing disease seen on either CT or MR enterography. About half of these patients had surgery within a median of a year. They developed a simple stricture score, which included the presence of internal fistula, presence of bowel obstruction, proximal small bowel dilatation above the stricture, presence of an abdominal mass or abscess, and mesenteric stranding. And if you look at the figure on the right, if any of those factors were present, biologic therapy was not more effective than no biologic therapy. Whereas if none of these factors were present, biologics could be fairly effective. So this is something that I use in my clinical practice all the time when I'm trying to decide whether I should initiate medical treatment for a patient or refer them directly to surgery. This is a study that we did at the University of Maryland, a smaller study looking at patients with both stricturing and penetrating disease. And the take-home message here is that with medical therapy, which could include multiple therapies, antibiotics, bowel rest, immune suppressant, biologic therapy, that medical therapy was often ineffective when complicated disease was present. And thinking about risk factors for a disabling disease course, we'll focus on Crohn's here and then move to ulcerative colitis. You can see on the far right that younger age at diagnosis, more extensive anatomic involvement, the presence of perianal and severe rectal disease, deep ulcers, prior surgical resection, and complicated disease phenotypes are a high risk group in Crohn's that are more likely to have a disabling disease course. In ulcerative colitis, again, extensive disease, so extensive colitis, deeper ulcers, younger age at diagnosis. Also, elevated biomarkers, CRP and SED rate, which is usually more reflective of extensive disease. Steroid requiring disease, particularly at the time of diagnosis. If you remember only one of these factors, a patient who's been hospitalized for their treatment of their colitis is a high risk phenotype. And then those that have concurrent C. diff or CMV infection. Going back to Crohn's disease, so if you've identified a patient that is high risk for disabling disease course, what does the AGA recommend? And I've modified this to include our newer biologics. Anti-TNF monotherapy is preferred over no therapy or thiopurine monotherapy. If you're going to use an anti-TNF, combination therapy is preferred. You can use methotrexate for those who don't tolerate a thiopurine. And then I've included Ustekinumab and vedolizumab monotherapy. For ulcerative colitis, for a bio-naive patient, a short course of steroids with initiation of a thiopurine or anti-TNF with or without concurrent thiopurine, vedolizumab, Ustekinumab, and really tofacitinib should reserve for biologic failure patient. And if a patient doesn't respond and you look at the far right, those are the options for the bio-exposed patient with more emphasis here on tofacitinib. So how do you determine how to position these therapies? So what I showed you hopefully was somewhat helpful, but I didn't help you sort out which of those agents you should use. So this is how I think of this in clinical practice when I'm talking to patients. So one, is there evidence that one agent is more efficacious than another? And I'm going to show you a little bit of data. How severe are the patient's symptoms? Can the patient tolerate, or is the patient amenable to a steroid bridge to some of the slower onset of action agents? What safety considerations are present? So is this an elderly person or someone with comorbid conditions? Is this patient someone who's very risk averse? Does the patient have a preference regarding mode of delivery, oral versus sub-Q versus intravenous? What type of insurance does the patient have? Particularly, does the patient have Medicare versus other forms of insurance? Does the patient have prominent extraintestinal manifestations? And if it's a female patient, is she of childbearing age? So there are a few randomized clinical trials comparing the different agents. We, of course, have SONIC and UC Success, but I'm going to focus here on the VARSITY trial, which compared Adalimumab versus vedolizumab for moderate to severe ulcerative colitis patients. This included those that were bio-naive and bio-exposed. And this was using standard therapies, no dose escalation, no therapeutic drug monitoring, treat straight through design. And you can see Adalimumab in blue, vedolizumab in gray. And looking at the one-year outcome, symptomatic remission was significantly greater in the vedolizumab treated patients, as was endoscopic improvement. Surprisingly, steroid-free remission rates were lower although this was not statistically significant. The next study is focusing on patients with Crohn's that had experienced failure to prior anti-TNF. This was a prospective registry from Europe, and what you're looking at here is steroid-free remission on the left and biochemical remission on the right. And you can see that Ustekinumab in gray by 1 year outperforms vedolizumab in blue. Likewise, if you're looking at biochemical remission, you see significant differences at 1 year. So in biologic exposed patients, Ustekinumab may be a better option than vedolizumab for Crohn's disease. Now, when we lack data, we often have to use network meta-analyses here. This is looking at moderate to severe Crohn's disease, bio-naive patients. You can see the greatest signal for efficacy for infliximab and adalimumab. For bio-exposed patients, you can see greatest efficacy for adalimumab and ustekinumab compared to vedolizumab. And we're looking here at ulcerative colitis. In panel A, you have the bio-naive patients. In panel B, you have the bio-exposed patients. Endoscopic improvement is in black. Clinical remission is in gray. And for bio-naive patients, you can see the greatest signal for infliximab and vedolizumab. And for bio-exposed patients, you can see the greatest signal for ustekinumab and tofacitinib. So this may help you position some of these therapies. What about extraintestinal manifestations? This was an interesting abstract presented at the recent American College of Gastro meeting. It was a multi-center retrospective cohort of patients with pre-existing extraintestinal manifestations who received at least one dose of vedolizumab between 2014 and 2019. EIMs were defined by the physician, and they included the classic extraintestinal manifestations that we look at. The primary outcome was worsening EIM stratified by whether they were arthritis or non-arthritis type. If you look at the top figure on the right, you can see that worsening is in purple, whereas stable EIMs is in orange. And you can see for the first three columns that you see more worsening of EIMs in the arthritic type symptoms compared to the non-arthritic type. And in the bottom panel, this breaks it down to arthritis versus no arthritis, and you can see that there is more worsening in patients who have arthritic EIMs. A third of these patients were on combination therapy. Most of them had Crohn's. The overall worsening rate was about a third, and there was no difference based on age, concurrent immune suppression, type of IBD, or IBD disease activity. Now, if you wonder, well, maybe this is just because vedolizumab didn't control the gut symptoms, there was actually no difference in worsening based on symptomatic remission or endoscopic outcomes, and approximately 10% of patients needed to discontinue vedolizumab because of the worsening EIMs. So just to briefly talk about perianal Crohn's disease, this is what we're talking about. This is DEFCON 1, the most severe Crohn's that we treat. What do our guidelines say about positioning of therapy? So it's primarily anti-TNF with an emphasis on infliximab because that's where the data is greatest. There's some efficacy for antibiotics. There's an emphasis also in drainage of the perianal abscess before anti-TNF treatment. And also remember that steroids are not used for fistulizing disease. So to summarize, the decision to start highly effective therapy is based on severity of symptoms, inflammatory burden, and risk factors for severe disease. Clinical remission and at least endoscopic improvement are goals of treatment. For patients with less severe symptoms or less inflammatory burden, elderly patients and comorbid conditions, safety first. I would recommend using ustekinumab or vedolizumab first line. For patients with more severe symptoms, infliximab or tofacitinib. Combination therapy or proactive therapeutic drug monitoring should be used in anti-TNF treated patients. For patients with prominent extraintestinal symptoms, anti-TNF therapy, tofacitinib or ustekinumab should be first line. Remember, for perianal Crohn's, combination therapy with multimodality treatment is indicated. And until we have further data on safety, avoid tofacitinib in women of childbearing age. Now I'm going to turn it over to Anita Afsali, who's going to talk about some of our newer novel therapies that are emerging.